Well, thank you, Dr. Ratner and Dr. Marks, for the invitation to speak today. These are my disclosures, none of which are particularly relevant for this talk. So if you think about a patient who's had a previous fundoplication, there's some things they may come back complaining of that could be an indication that something's wrong. Some of these things include dysphagia, bloating, or even recurrent reflux. So what are the reasons they may have dysphagia? Well, it could be completely normal, particularly in the early post-op period. That may be just due to edema, but maybe there's something else going on. And that's where you have to think about a functional problem, such as esophageal dysmotility, or maybe there's a mechanical problem. The wrap could have herniated, have a hiatal hernia in general, slip nissen, or maybe the wrap's too tight. So early post-op, I think, is different than if the patient presents later. Early, you're going to try to work them through, treat them with a PPI if they need it, make sure they're following your dietary instructions. Maybe they've been aggressive with restarting foods, work with reassurance. I like using hyoscyamine to help with some potential spasm. But if those symptoms persist longer, that's when you need to start looking at other things. So I'll do an endoscopy 4 to 6 weeks out if they still have some symptoms. And then you need to consider a dilation potentially if everything else looks okay, but I would wait at least 8 weeks before I would consider that. If their symptoms are very severe, even early on, or if they persist longer, that's when I would do further workup. So some of the other things you may see on those barium swallow or in the later patients, if they get new achalasia or pseudoachalasia, they may have progressive dysphagia to solids or liquids, chest pain, regurgitation. They may even have weight loss if it gets severe enough. And I've definitely heard patients who have recurrent symptoms and present with aspiration. So that barium swallow is the first test and can be really informative in these patients. Some of the main things that you may see, you see the normal here on the left and 2 abnormal studies on the right, is looking for that wrap slipping up above the diaphragm or other functional abnormal findings. Here's another more severe recurrence where the wrap is really slid up and you're really getting a paraesophageal component as well. So you would want to do your evaluation, look at functional testing. I actually use high-resolution manometry now, but try to really figure out if everything's working right in the esophagus as well. If you have dysfunction, that probably means that that wrap is relatively or actually too tight. So that's where you would consider taking that patient and setting them up for a procedure to loosen the wrap. I also think it's worth considering some of the other options, where I use a Roux-en-Y occasionally because I think it's a great procedure that can help with that, even if the patient doesn't suffer from morbid obesity. Other evaluation that you can find on that endoscopy is looking to see if the wrap is too tight, not even letting your scope through, and it can also help you find out from a hiatal hernia or slip. It can also be therapeutic, so if everything looks good and the wrap's a little tight, a stretch with a balloon can be helpful. And again, make sure it's at least 8 weeks after the original procedure. Bloating is another thing that may present in the early patient as well as later. Can be normal. Our reflux patients tend to swallow more. They're trying to clear out their own esophagus. They've been trained to do that. But also we may be affecting the stomach emptying. We definitely are not letting things bounce back up that used to. So I would start some medications early on, Reglan or erythromycin. Make sure you have good dietary counseling. Consider simethicone as an early medication. Also get gastric emptying testing to really see if it is significantly abnormal or if it's just that the patient's getting more perception. If you have bloating and you actually on functional testing have delayed emptying, that's when you might want to consider doing a more aggressive thing, such as an endoscopy with a dilation, maybe even the version of POEM that treats the pylorus or a pyloroplasty. Now let's talk about recurrent reflux. This would yet again be another reason for revisional or reintervention therapy. So if you have it, start with medications, PPI, carafate, behavioral and dietary measures, but then look again for a mechanical reason that's not going to be managed by medications. pH and manometry, barium swallow endoscopy. If that happens, you might actually want to consider surgery. So some of the things anatomically that surgery fix: disrupted wrap, sliding hiatal hernia, slip or herniated wrap. And these are things that we all need to consider. These are what they might look like on endoscopy. There's a herniated wrap where you can see the diaphragm, or a slipped wrap when the wrap itself is mislocated on the stomach. So if you find something wrong, that's the easiest indication. That's when you fix it. Again, I think Dr. Ratner mentioned this in his talk yesterday. If you keep fixing it and it comes back more often than once, that's when you need to consider that reoperation, though, may not work, and you might need to have an alternate strategy, such as esophagectomy or maybe that gastric bypass. So, a quick summary points: there are a lot of things that you can treat. Not all of them need surgery, so try the medical options first. See if you can get them better with adding PPI, potentially helping their gastric emptying. Medications can also be the only answer, but if you have a mechanical problem and you have structural problems as well, that's when surgery is indicated. And remember, more operations aren't necessarily better. Thank you.